firstly, integrated care programs are usually complex, they're multifaceted, with lots of different elements, they're multi-level, so they will have some activities of the whole system, some affecting organisations, and some operating at the local health delivery level, so affecting individual users and patients. So they're complex initiatives to evaluate. The second reason that they're complex to evaluate, I think, in the contemporary healthcare system is that, in a way, everywhere you go in the world, people are trying to implement integrated care of various types. So if you're doing an evaluation and you want a comparison, you want a group that a population that's not exposed to integrated care, it's quite hard to find such a population. Another problem, another reason why integrated care is hard to evaluate is that it's impossible to define. Or should we say, in the literature there are, I think, 170 different definitions. And the reason there are so many is not because people can't agree, but it's partly because each system has a particular kind of challenge in terms of integration. The most obvious thing is to think about the objectives of the programme. And just as definitions change, I suppose the range of objectives of a programme will also change. Or sorry, there'll be a range of objectives. So I guess a good evaluation will try and represent the range of objectives. Typically, these days, I think you find that people commissioning evaluations of integrated care want a range of outcomes to be assessed, as well as costs. So everything from trying to understand whether the programme changes the pattern of healthcare use. For example, does it reduce hospitalisation, particularly unplanned hospitalisation? Does it actually therefore affect the kind of services people get in receipt of in the community? So first of all, just looking at the direct effects on patterns of utilisation. Then perhaps a bit more ambitiously, what does that mean for the cost of managing a particular person, say with diabetes, for a year? Has that cost gone down? Is the pattern of service that we're getting through a more coordinated pattern of care, is that cheaper? So I think in many countries at the moment, the question of whether various forms of integration lead to cost savings is pretty critical from the point of view of policymakers, particularly the policy agencies that are funding integrated care. I mean, the short answer is that it's probably no. At least we don't have a huge amount of economic evidence about integrated care programs, partly because it's difficult to assess cost effectiveness of integration initiatives. But what we do have doesn't suggest that they're particularly likely to be cost reducing. I mean, one possible reason for this is that if you improve the coordination of care, you may well bring more people into the care system. You may identify more unmet need. Generally, that's what happens when we move resources, for example, out of hospitals into community settings. We identify more people. So it may be that we simply increase the coverage of a system that may increase cost. There's going to be a need for quite a lot of different evaluations in different settings because of the many definitions of integrated care, because of the many issues that are specific to a system, where the initiative starts from, who's leading it, which organisations are most likely to need to make the biggest changes, will depend on where you start from. So in England, the big challenge is the biggest challenge is the interface between the National Health Service, so the healthcare delivery system in the public sector, and the social care or long-term care sector. That's the interface which, for a big chunk of the population that are relatively high users of healthcare in older life, that's the population for which the way in which they're able to access social care becomes crucial. And in England, those are two separate systems with different systems of funding, different systems of accountability. So in social care, we have a means-tested, subsidised system administered through local government. On the healthcare side, we have universal, free at the point of use, funded system through the NHS. And we are struggling, but trying to focus very much on how to make those two sets of resources and organisations and funding streams work better together. guess it would be easy for me coming from outside Australia to say, well, you just need to focus more actively, bring the politicians at the two levels of government together, because clearly the relationship between hospital sector care and what goes on in primary care and GP care is fundamental to making the best use of resources. But I think that would be perhaps a bit too glib, particularly for an outsider. I'm just speculating, but I wonder whether the focus perhaps at state level would be, with the help of the Commonwealth Government, would be more focusing on the relationship, for example, between general practice, community health services and the long-term care or the social care sectors, whether that's a more promising way of developing better coordinated care, particularly for people with high-level complex chronic conditions in older life. I think given that, for example, the evidence about being able to use better coordination, at least in the short term, to reduce hospitalisation, doesn't seem to be terribly strong. It may be, and this is entirely speculation on my part, but it may be just as valuable to think about the relationship between what goes on in social care and what goes on in primary and community services as to worry about that really difficult relationship between the way that you've got a primary medical system and pharmaceutical benefits funded and administered at Commonwealth level, and you've got hospital services administered and funded at state level.